Thank you very much. It's a great honor, privilege to be in Tokyo and to be able to share in this exciting meeting. And my task is to talk a little bit about the pharmacology of integrase inhibitors and just a few disclosures, particularly around the websites that we run in Liverpool for HIV drug interactions, hepatitis drug interactions, and cancer oncology drug interactions. I think we'll just talk a little bit more about them as we go through. And it's also been a privilege to work with NCGM on translating the hepatitis resource. And this is being launched by NCGM, and I believe it's being greatly used in Japan. So we're very privileged to be linked to NCGM working on this particular project. The roadmap of my talk is going to be a little bit about the background of the pharmacology of integrase inhibitors, talking about comorbidities and polypharmacy. How do we evaluate whether a drug is going to interact? Are there interactions particularly of concern? And then if we have time, we'll look at a case. So the background of the pharmacology of integrase inhibitors, I think probably we should start with a pharmaceutical issue, which is if you look at the four integrase inhibitors, there are different dosages clearly of those drugs. So raltegravir has a BID high 400 milligrams or 1200 milligrams once daily, elvitegravir being boosted, dolutegravir and bictegravir 50 milligrams. And we have fixed dose combinations of different combinations. Only raltegravir has not got a fixed dose combination. And linked when you look at the pharmaceutics is the size of the pills, because the amount of drug that you have clearly governs how big the pill is going to be. So you can see that the dolutegravir-abacavir 3TC fixed dose combination is bigger than the ECF-TAF, which is bigger than the BF-TAF. And also a slight difference, certainly with the ECF-TAF of having to be taken with food and the others with or without food. So these are pharmaceutical aspects of the drugs. Another important aspect is that the integrase inhibitors per se are not renally excreted to any extent. So if you just looked at the integrase inhibitor, raltegravir, no dose adjustment in renal impairment, dolutegravir on its own would be no dose adjustment. But in the fixed dose combinations where you clearly have then to think about the NRTIs, it is that which governs the restrictions that we have around renal impairment. So if you look, for example, at the elvitegravir Genvoya, you have a different governance of that interaction compared to Stribild because of TAF versus TDF. And then with dolutegravir in Triumec, you have the 3TC, which is the important aspect for making a judgment about its renal impairment dosing. So these are important aspects. As far as the metabolic aspect, the metabolism of the drugs, they are not the same. So raltegravir is governed by UGT1A1 enzyme, and bictegravir combined UGT-CYP3A4, then dolutegravir mainly UGT1A1, elvitegravir mainly CYP3A. So because a drug is in a class, does not mean it's going to be handled in the body in the same way. And the way the drug is being handled in its metabolism then governs its drug interaction potential. So the highest potential is elvitegravir because of the boosting by cobicistat. The lowest is raltegravir because it is governed by UGT, not by CYP to any extent at all. So we have a different magnitude, therefore, of the drug interaction potential of the different integrase inhibitors. One final factor, we could talk a lot about different factors which are important, but a final factor is the inhibitory quotient of the drug. Now, by the inhibitory quotient, it is the drug concentration, which we normally regard as the end of the dosing interval concentration, the trough, over the EC value of the drug, a protein-adjusted EC90 or EC95. So we have the different values here with dolutegravir and bictegravir being very much the same, around 16, 17, and the raltegravir and elvitegravir being around 8. Now, we'll talk a little bit more, I'm sure, when we talk about resistance around the point of the drug concentration over the value for the particular HIV species. So the second aspect is to talk about comorbidities and polypharmacy. There are a number of huge international studies, and these are just 4, the NA Accord, the DAT-AIDS, the EuroCEDA, and the GEPO studies, which have documented the prevalence of comorbidities and other conditions in people living with HIV. And these studies have been categorized by age, so you can break it down by different bands of age. And for example, in the GEPO study, the one in the bottom corner, patients over 65, it wasn't just the age which was governing the comorbidities. It was also the length of time since infection which had an impact on the comorbidities seen in that particular grouping. Now, linked to comorbidities is polypharmacy. And polypharmacy is normally defined as at least 5 non-antiretroviral drugs. There are many, many studies. The one in red is a study from Japan, which I would just like to go into in a little bit more detail. But overall, the prevalence of polypharmacy in patients who are greater than 50 years of age is around 30 to 50%. So they're taking more than 5 co-medications in around 30 to 50% of patients. So this is the study from Japan, polypharmacy in acute care hospitals. And the study is people living with HIV greater than 18 years with a diagnosis of HIV and prescription records of their antiretrovirals in that window of 2010 to 2015. 1,445 patients from the Medical Data Vision MDV database in Japan. And I think what we can see is that the number of comorbidities clearly increases as you categorize by age. Greater than 5 comorbidities here, the red, 4, 3, 2, and 1. So increasing comorbidities, but also then increasing the number of co-medications. So the prevalence of polypharmacy is increasing in this study in Japan. So that would mirror what we have seen in many of the huge international studies as well. But also then breaking it down, comparing polypharmacy in acute care hospitals in Japan versus HIV negative. And the number of HIV negatives is 10-fold times greater than the HIV positive. And here we can see the difference in the percentage of patients with polypharmacy much greater in those who are HIV positive. Now, where this study slightly differs for some of the international studies is that other studies have shown a convergence between HIV positive and HIV negative towards the higher age groups, which is not seen in this particular study. So that is an interesting difference, maybe between the Japanese study data and some of the other studies that we have. But I think the key message from this part of the talk is that we are in this age of older patients with multimorbidities and polypharmacy, and sometimes polydoctory, i.e. more than one doctor, some doctors having an impact on the treatment of our patients, which can lead to an increase in the pill burden, obviously, with the number of pills being taken, a decrease potentially in medication adherence, an increase in the possibilities of having prescribing errors when you have more and more pills. But at the heart of this is drug interactions, where when you have multiple drugs, the potential for drug interactions to reduce the efficacy of the HIV drug, or to cause adverse effects, or to have an impact on the co-medication. And the two terms of perpetrator, where the antiretroviral drug could be a perpetrator of an interaction or the victim of an interaction. So those two terms are now often used. So let's really just reinforce that message that we have to think when we're treating older patients in particular, not only older patients, but in particular older patients, of this issue of polypharmacy. So how do we know whether a drug is likely to interact? How do we evaluate a drug interaction? Well, during drug development, we will get an idea very early on in preclinical studies whether a drug is likely to be a perpetrator or a victim, or maybe both, of a drug interaction. Studies done early in development. This will lead into phase 1, early phase 2 clinical drug interaction studies, where we have an idea of a mechanism and try to study that mechanism, or target specific drugs that are likely in our population of patients. And then during development as well, we can use what is termed PBPK modeling, which is physiologically based modeling, which is a systems approach of getting virtual patients from data inputted into models, which requires a lot of input of physical chemical data, of data during development of the drug. But we can get virtual patient populations without doing the clinical study in order to define a drug interaction. And then real-world data will emerge as we have a development during the big trials of population pharmacokinetics and case reports. And this is all governed by regulations. So the FDA regulations of clinical drug interaction studies, the European Medicines Agency regulations, and the PMDA in Japan with the regulations around drug interaction studies. Now, that feeds in then to the label. So we have the label for each drug. And within the label, you have a section on established and other potentially significant drug interactions. So here for dolutegravir are some of the drugs listed in the label. And we have some reds. Now, red means contraindicated or should be avoided. So you can see some of these reds. And then we have an orange color, which I've put here, which means a cautionary statement about having to do something for that drug interaction. So you can see that list in the USPI, the US prescribing information. But interestingly, if you then look at the European label for the same drugs, you have differences not only in the recommendation, but sometimes differences in the wording for those particular drugs as well. And only 4, the drugs with the ticks, have exactly the same wording. You then come to the Japanese prescribing information, and you limit it even more. So the difference now between the USPI and the European label and the Japanese label can be different wording, but also different recommendations. It's not only dolutegravir. We see this with bictegravir. So with bictegravir, we have a list of 20 co-meds listed, not all listed in the different labels, but the SMPC has 19 of the 20 listed with contraindications, not recommended. But then notice the USPI, some of those reds in the SMPC are now orange color because it says do something rather than not recommended or contraindicated. And there is only one which you have the same wording between the USPI, the SMPC, and the Japan prescribing information, where you have the same wording. And some of the drugs are not mentioned either in the USPI or the Japan prescribing. So there are clearly differences in the way regulators, in discussion with the pharmaceutical companies, come to a decision around what information is given to us in the label for a drug. And my view is that I would like to see us be a little bit better at coming to the best conclusion for the different labels, rather than having what can be confusing at times is what is the real bottom line recommendation for a particular drug interaction. Now, this has been highlighted in a paper published just last week on the assessment of consistency of drug interaction information in labels from the United States, the United Kingdom, China, Japan, and Korea. And they looked at 38 study drugs, looking at all the drugs listed in the label for those 38 drugs, and there were 1,727 co-meds listed, which is an average in the label of 45 drugs, which are said to be an issue that we have to think about. So if you just scan along, in contraindication, the US said 12.6% were contraindicated. Japan said 4.2% were contraindicated. In the cautious statement, we have in the US 28.3%, and in the Japan label, higher number of 38%. So it's interesting to see the difference between different labels. This is not just HIV drugs. These are drugs from different therapeutic classes. Again, the question of the consistency of the label information, which we have in different territories, in different countries. Now, I know that this is a big topic, and I'm just giving the top line at the moment, maybe for some discussion and some with colleagues later. But it's a really interesting point, I think, of how we get the information that we do have. So product labels are vital. So much work goes into a product label. And that is the basis on which we have our drug interaction data. But there are gaps. And other resources, therefore, are necessary. And we need to understand mechanisms of drug interactions in order to be able to fill these gaps. So which interactions are of concern? Maybe the first question is, when is an interaction of concern? And the answer to that is when co-administration leads to a safety, efficacy, or tolerability issue which is greater than when a drug is given alone. So when it's co-administered, is there more issues that we have to think about relative to efficacy and tolerability? And it's because of that that we've produced our databases and our drug interaction resources. This is the HIV one. It's got all the HIV drugs, 750 co-medications. And we can interrogate our database in order to get useful information. So we can look at all of the 750 co-medications against each of the antiretrovirals and ask the question, where is the greater risk of a drug interaction based on the categorization of green, which means there's no interaction, red where the drug should not be co-administered, and we have the orange color of interaction of a clinical relevance, where you have to do something. So the highest number of greens is raltegravir, dolutegravir, bictegravir. So the integrase inhibitors have the highest percentage of no drug interactions. Whereas the boosted antiretrovirals, where you have a booster, you have much less, only about 50% of your co-medications are not considered for a drug interaction. And with efavirenz, which from this morning's discussion, efavirenz clearly is still a drug which is an important drug in many settings, you have around 50%, where you have to think about the drug interactions for the co-medications. Now, a second question that we can use from our database is to say, what are people actually looking for when they search the database? We track every single interaction that is searched for. And in 2018, there were over 4 million searches for drug interactions. And we asked the question, globally, what are people searching for? Well, the highest search is for statins. So the number of searches for statins, for atorvastatin, around 50,000, and the other statins in the green are in the top 20. Followed by proton pump inhibitors. People are searching for drug interactions with proton pump inhibitors, anti-diabetic drugs, analgesics, antihypertensives, other anti-infectives, psychotropic drugs, and increasing all the time are the novel oral anticoagulants, the newer drugs for antiplatelet drugs and anticoagulant drugs. So this is what is being searched for. Now, what is being searched for in Japan? Well, if we look at the top 10 medication searches in our database from Japan, well, the highest number is with clarithromycin, which is interesting, followed by atorvastatin, and another statin, rosuvastatin, is also very highly searched for, as is rifampicin and metformin. So here we know what is of interest to search for in Japan based on our database. We can then look at this data in comparison with the Japan Hospital Claims Database, which monitors the drugs which patients are on. So the 10 most common medications in the study, which I've referred to already, in the 1,400 patients, antacids was number 1, followed by antibacterials, followed by psychotropics, systemic antihistamines, and the lipid regulators. So we know the drugs that clearly are being used in patients, which are being searched for in our database, and maybe where we need to have educational initiatives around making sure that people are aware of the potential or non-potential of a drug interaction. So just 2 points I want to make. One is the drug interaction with statins, because the interaction with statins is either with a booster or with efavirenz stroke etravirine. So we have here just an example of where the interaction with a cobicistat-based adaxanivir-cobicistat with a different statin, you can have a different magnitude of interaction. Elvitegravir-cobicistat is expected to interact, but we don't have any studies with that boosted regimen. So we have to look and we have to see that the difference in extent of interaction can be seen with different statins, but the label is informed by the information that we have from a study or even a non-study, which gets into the label. But really important to note that dolutegravir, raltegravir, bictegravir, NRTIs, none of those drugs interact with statins. So sometimes there's a danger of dosing suboptimally in patients because we're concerned statins interact with antiretrovirals. But it's only some interactions that we have to think about. So there was a study from London, from Chelsea and Westminster, which showed, for example, that greater than 50% of patients failed to achieve their target lipids when they were on antiretrovirals because there was suboptimal dosing of the statin due to a concern of drug interactions, sometimes which didn't exist. So you have to know whether an interaction is actually going to take place. So sometimes you can suboptimally dose because of a fear of a drug interaction which may not be real. So you have to have both things in your mind. The other interaction, just to mention, is with antacids. We need to bear in mind that there are different classes of antacids. So we have the proton pump inhibitors, none of which interact with raltegravir, elvitegravir, dolutegravir, bictegravir. They do with dolutegravir rilpivirine because of rilpivirine, not with the integrase inhibitor. It's because of the acid liability of rilpivirine. However, with cation-containing antacids, all of the integrase inhibitors can interact because of the mechanism of the cation binding to the integrase, and therefore you get decreased absorption. And we have recommendations, sometimes actually are not recommended, depending on the integrase inhibitor and the different cations, many patients are taking this sort of drug containing aluminium or magnesium or calcium or iron. These cations can all interact with the integrase inhibitors. And there's really important information for each of those drugs that we need and we haven't got time to go into. So the key question when we interpret pharmacokinetics is what is the magnitude of the change? What is the clinical significance when you've got a change in the exposure of the drug? And then how do you manage? It's all about management. Drug interactions is about managing the patient and knowing and having that information. And it's drugs with a narrow therapeutic index, which are clearly the important drugs. So it may be necessary to change a co-medication or to change the antiretroviral if the co-medications can't be changed. And it is necessary because you cannot remember all the interactions to use some sort of drug interaction checker. So in the last 1 minute, a case, very briefly. A Japanese gentleman, 62 years of age, recently diagnosed with a viral load of 105,000. He's HLA-B57 negative, renal function of 50, with a complex medical history of comorbidities. And to manage these comorbidities, he's on these medications: amlodipine, atorvastatin, dabigatran, digoxin, sitagliptin, omeprazole, quetiapine, so a whole range of different drugs. We want to start this patient on an integrase inhibitor. Is it good or bad? Well, you look, and if you look for all of the big drug, dolutegravir, raltegravir, everything is green. There's no interaction. The issue is when you've got a booster, because the booster then leads to contraindications with dabigatran and quetiapine and some orange interventional aspects with some of the other drugs. So when you're faced with this sort of complication, then you have to think, and we have to know and have the information to hand. So drug interactions are practically unavoidable, but mostly manageable. Older patients are at risk because of comorbidities. We need to have resources, and we need to think about how we're going to often think about eliminating medications which are not essential when you've got an older patient. Greater consistency in prescribing information, and we enter the long-acting field now. How do we deal with drug interactions in long-acting? And we have to really work that through going forward. Thank you very much for your attention.